we are going to go to our next activity, that is our panel, and I want to introduce you our phenomenal leader and PI coordinator, Camila Davis. And she is going to introduce our panelists.
Thank you, Shilpa. Please excuse me, we have a long script you're going to see me flipping through. But just wonderful to see everybody in the room, those who I haven't met yet, those who we've been working with, either for a short time or a long time. We really appreciate you all being here. There's a lot of love in this room. Okay, my name is Camila Davis. I'm a health education specialist and program coordinator for the Perinatal Equity Initiative, and I have the honor to moderate today's panel discussion. So as we all know, women of African ancestry face disproportionate risks of maternal health challenges compounded by systemic inequities, such as racial bias, unequal access to healthcare, and social barriers. As long as these have persisted, people in our communities have actively fought to end these disparities, adapting to changes in the political and fiscal climates through creativity and solidarity. For our next portion of the conference, we will hear from a multidisciplinary panel of experts. Our distinguished panelists have a unique mix of professional and personal experiences, and collectively will be able to provide a comprehensive insight into the current maternal health equity space. It is my pleasure to introduce our esteemed panelists. First, Dr. Cassondra Marshall. Dr. Marshall is an associate professor in the Maternal, Child, and Adolescent Health Program at the University of California, Berkeley School of Public Health. Using mixed methods and implementation science, the goal of her research program is to advance reproductive and maternal health equity by developing, implementing, and evaluating person-centered interventions and care delivery models that improve the health of underserved populations. She has also had an active research portfolio focused on community doula care as an intervention to improve maternal and infant health equity. Dr. Marshall also focuses on healthcare delivery strategies to improve family planning care for women of reproductive age with diabetes, hypertension, and other chronic medical conditions. Next, Ms. Christina Oldini. A nurse and associate director at the California Maternal Quality Care Collaborative, has worked in the Sutter Health System for over 30 years and now leads quality improvement efforts on behalf of women, birthing persons, and newborns. She led the development of task forces to guide the work on substance use and exposure for pregnant persons and newborns, as well as perinatal equity. She is honored to be on the DEIAA committee of the Association of California Nurse Leaders, and acts as a mentor at her alma mater, the University of San Francisco. Go Dons. That's off script, okay? She is a member of the National Black Nurses Association and DMPs of Color. Lastly, she feels fortunate to be on the interview panel for prospective medical students at Stanford and feels hopeful about the future of healthcare. Okay. Next, we have Dr. Noha Aboelata. Dr. Noha is a family physician and the founding CEO of Roots Community Health, an Oakland-born organization dedicated to whole health, a community-driven model addressing the health of individuals, families, and the collective ecosystem. Under her leadership, Roots has grown from a two-person volunteer effort to a multi-county clinical and social enterprise with over 250 staff, providing more than 36,000 medical and navigation visits annually across Alameda and Santa Clara counties. A graduate of Howard University College of Medicine and a National Health Service Corps Fellow, Dr. Aboelata has pioneered innovative programs reaching those most marginalized by the safety net, including street medicine, reentry support, and workforce enterprises. She is a primary leader in the 40 by 40 initiative, a large-scale collective impact strategy that has secured a generational $100 million investment for Deep East Oakland. Beyond Roots, Dr. Aboelata serves as vice chair of the Alameda Alliance for Health Board of Governors and as a commissioner for the future of Medi-Cal. An Oakland native, she remains a fierce advocate for dismantling systemic barriers and honoring the cultural heritage of the communities she serves through high-touch, gold standard care. And I'll also add that our community here in Santa Clara County has benefited immensely from Roots Women of Wellness and doula programs, also tabling in the back here, along with Anthem to her right. And so Roots Women of Wellness and doula programs have supported hundreds of Black women in Santa Clara County across their reproductive lifespan. And last but not least, Miss Niambi Lewis. Ms. Lewis serves as the chief for the Perinatal Equity Section in the Maternal, Child, and Adolescent Health Division at the California Department of Public Health. In her capacity, she is responsible for the oversight of the Black Infant Health and Perinatal Equity Initiative programs. These programs have been tasked with providing support to Black pregnant and parenting mothers and their families to mitigate the harmful impacts of racism and ultimately improve birth outcomes. For over 20 years, she has been employed by the state of California, over a decade of that service working within departments in the Health and Human Services Agency, supporting her desire to work for programs that serve communities most impacted by the effects of structural racism. Prior to transitioning to public health, Niambi spent several years with the Department of Social Services, where she focused on the oversight of child welfare programs statewide, with special focus on decreasing the disproportionate rate of Black children entering foster care. So similar to our opening keynote, please write down any questions you have on the cards provided or via Q&A online as you hear the speakers, and we'll select audience questions towards the end of the panel. Okay, so we'll start with a question for everybody, and we all have mics, great. So tell us, what are you proud of that you've accomplished in your career in regards to health equity?
Yes. Well, I would say definitely leading Roots and leading the growth of Roots. It's really being able to center the folks who've been most on the margins for too long, not only in their care, but also in delivering the care. So being our workforce. And so for me, seeing that transformation of someone who may even start out as a patient or a client, go through workforce services or different offerings that we might have outside of just clinical care, and becoming that workforce and becoming that change in the community, and how transformative it is for them. But then also how many people's lives they're able to touch. And so seeing that kind of self-fulfilling, I think is probably my proudest achievement.
Okay. For me, I will say in 2018, we got some new funding for the State Department. So it was the funding that helped us establish PEI, but also we got additional funding for BIH. And I took that time to be very intentional about how we did that work. So for many years, BIH, people said, like, this program has been in my community and I knew nothing about it. And so we set aside money specifically to allow the BIH coordinators. It wasn't the State Department doing the public awareness campaign. It is all led by the local health jurisdictions, and they have been so creative in the work that they've been able to do, but it's because they are the ones in closest community with the participants we're trying to serve. And so, yeah, that work is amazing, so I'm incredibly proud of that. And then PEI in itself, we got the legislation, we had the money, and we could decide how it was rolled out in our communities across the state. And again, I was very intentional about involving community in order to have the participants that we want to impact be served. And so I'm really proud of that work in PEI as well.
Both of those are amazing accomplishments. Wow. Yeah, and I do remember, like, when the PEI stuff was rolling out, and it was such a change from the past. That's really incredible. I think for me, I think a little bit similar to what was spoken a moment ago is really being proud of being a part of the development of an MCH workforce that is diverse, that's focused on equity, teaching classes that call out racism as a root cause of maternal health inequities. And I love teaching and mentoring. I love affirming students who come into our program and say, flat out, I want to work on Black birth equity. I've had several students do that, and it seems simple, but to affirm them and say, okay, that's what your focus in this program is going to be, whether these are my Master's of Public Health students or my PhD students or my Doctor of Public Health students. A lot of students haven't had a professor look at them and say, great, we need that, let's do it. And just affirm that this is real, it's scientific, it's meeting a need in the community. And so I feel really honored to be in a position to affirm them and then to see them at graduation, like getting their job and going out to do that work. That's more meaningful to me than any paper I've published that no one really reads anyways. So yeah, I think just really being part of workforce development and affirming people's goals and desires, because the talent is out there. It's really just kind of building upon that.
Good morning. I'm going to cheat. I have two. The first one, I'm 62. No, there's not one of them. Okay, you could, all right, I am proud. Okay, fine. The fact that I have come to a point in my life where I'm not afraid to have a conversation. And I'm not afraid to make a mistake. So that's number one. And then number two is I'm very proud of my leadership career in terms of growth and development for folks that report to me. I take that role very seriously. I'm very fortunate. I have two fabulous colleagues from CMQCC here today with me. And that's something very important to me because that's the future. That's the future, and we need to care for them.
Wonderful. Next question. And folks, please feel free to, just jump in, although there are some that have indicated right this question. How have you elevated the voices of clients to inform clinical or healthcare policy? Yeah, Dr. Marshall.
I can take a first stab. I'm going to kind of adjust it to my life because I'm not a clinician, but I do advance, hopefully, healthcare policy. I mean, I will say, and this kind of builds off of what Dr. Franklin was talking about a moment ago in terms of evidence and things like that. But I think for me, it's basically how do we incorporate community voice into research and how data is generated and evidence is generated. And I think if you've been kind of trained in the traditional model of research, you've probably been on a journey on kind of what you learned is not what you're doing now, hopefully. Not that there's no good in that, but kind of expanding the way that we listen to community. So I can just give one example of something that I've done in my research that has really changed the way that we write grants and changed the way that we conduct our research, which is starting with community voice. So typically in research, you want to, or not just in research, probably like in anyone who does nonprofit grant work or whatever, well, maybe the nonprofits are doing better than us, but you get the researcher, the academic side, get the question, and then you go out and seek the funding, you write the proposal, and then they're like, oh, we're gonna invite patients, and we're gonna have community, and we'll have an advisory board. But the truth is, you have come up with all those ideas. You've come up with the topic for the study. You looked at the literature, and then the intention, some people don't even do this, but hopefully community voice will come along later. And that's how things are systemically organized, right? There's no grants to involve the community. The grant comes after you already have identified the question. There's no money given to actually pay people to give us their ideas about what we should study or what's important to them. The people who are usually doing that are just really good researchers who have good community connections. But anyways, I found money that it did allow us to do that. And so we did something called research prioritization, which means before, it's no research. It's literally just, let's go to community and hear what questions are important to the community. And what that allowed, and it's a systemic process, there's papers written on it, there's ways to really elevate, get at what are questions that aren't answered that everyday people want to know and will impact their lives. And anyways, we went through a process like that. And and we generated like hundreds of research questions. And so now I always have that to go back to before I ever write a grant, before I ever engage in a research project. It's like, if it's not on that list of this was important to community, then why am I doing it? And so just like that's one technique or one model we've used to really elevate those voices. And so now in my role, I can go to a funder and I can write the science and what have you, but it starts with, this is a process that I went through in collaboration, where community members said this was important to them. And so it's just a small tweak, but I think it's so important.
And I'll just add for PEI, because I'm not clinical either. Part of what's embedded in Perinatal Equity Initiative is that they have to have a community advisory board, to your point, but the community advisory board is guiding all of the decisions about the intervention. And so the community advisory board should have suggested the interventions that were implemented initially. And before the county can change what the intervention is, they have to go back to their board and do a turn the curve and figure out. And so it's like really embedding, as you were saying, having the community voice in the decisions that are made. We have to fund the counties, it's just the way the legislation was written, but we want to be sure that the community voice is represented in those interventions.
Yeah, there's so many examples I could give. I'll probably, well, first and foremost, I'm going to say that once again, hiring from the community, training folks from the community, investing in them with full-time benefited critical roles within our organization is probably one of the most important ways, because then they're involved in everything as well. And so I'll just say that part off at the top. But I will also say that a big part of how Roots has grown from just 2 volunteers into a larger medium-sized organization has been very iterative, right? Like listening to community, what's needed, and then trying to build around that. We have what's called the People's Advisory Council in East Oakland, and it's really some of our neighborhood-based work. And that is really where we have been hosting a community learning system, really. So we have what's called a community data trust and a learning system, and it's really residents that are lifting up their priorities. Like, this is what I'm worried about. I'm worried about violence in my community. So how do we go deeper and get our questions answered? Because we all know there's a lot of data out there, but how it's used, sometimes it can even be weaponized against the community, right? So we want to know, like, what is the community saying? It's often very different than what's in the headlines, right? About what makes them feel safe, if we just even are taking that one example of community violence. And so through the learning system is what questions is community surfacing, and then where can we get the answers? So we brought in city leaders, county folks, data specialists to give what the data is saying, and then communities are really interrogating that, right? Because it's about them, but it was all analyzed without them in the room. And so now they're getting to take a look at it and analyzing and say, well, wait, they called that my neighborhood, but that's not really our neighborhood. Our neighborhood is really this. And when they said that this incident was about that, no, we know it was really about this. And so what that's lifting up for us is a lot of the data we collect is encoding all the biases that we keep seeing. And so when community is able to say, well, what about this data on the ground? How do we get this ground truth data and really collect some novel data on the ground? And so for us, that would really that's the ideal state, right? Where the community is the one asking the questions, getting their questions answered, and then saying, okay, well, these are the gaps. So this is where we think the investment needs to go. And so that they're getting to drive actual investments in their community. So that's really what we've been practicing. And so that's outside the exam rooms, even though I'm a clinical person and that was your question. Yeah. I think this all has to happen outside of the context of our systems. It actually should be held within the community.
Thank you so much. And I love that, all these questions thus far and all your answers have focused, really on community, those impacted, and thinking about that larger circle from your presentation. This next question is more intra-organizational. We'd like to know, how do you hold peers accountable?
Look in the mirror first. So I want to tell you a story. I visit with my colleagues hospitals in various locations in California. We meet with nursing teams, social work teams, and others. And years ago, before COVID, I had gone out to a hospital. And at that point in time, remember many of us used to bring papers with us? Right? Tons of information and flyers, and we'd put them all out on the table. And so I did our meeting with this nursing leadership team, and we were closing down the meeting. We were done. And they got, they chose what they wanted to take with them, and they began to depart. And they chose everything except information on caring for the Black population. And I said to them, hey, you guys forgot these. And they said to me, actually, we don't really care for, it's very rare that we have a Black mom. Did I say anything? 7 years later, would I say something? Yes. And what I would say to them is this: you need to take those even more than the other stuff then. Leave the other stuff, come back, and take those flyers then. Because if you don't care for those folks often, you're going to need that information. And you're going to need to have it nearby, and you're going to have to refer to it so you can care for them as unique individuals and support what they need. Accountability. I'm a nurse. I'm 62 now too. I'm a nurse. One of the kind of my areas that I have most concern about in this area, and Noah can probably feel this, is that I have most concern about middle management, supervisors and managers being able to do and teach the work, and then being able to evaluate it appropriately so they can hold people accountable. Now, please don't take that for there aren't great nurses and respiratory therapists, supervisors, and sonography supervisors and managers of ultrasound and doing the work. There are some great ones in the state, there are. And there are many who are not equipped to do this work. And however, there are seniors potentially who also may not be equipped to do the work, let's lay that down there too, have to hold those supervisors and managers accountable, just as they have to hold the staff accountable. So that is work we have to pursue. We're thinking about it more at CMQCC with our health equity work. But that's one of my concerns. And that's what I referred to earlier about even having a tough conversation, right? Because if you can't have a tough conversation, how do you really teach? How are you genuine? How do you not only listen, but really hear what someone's telling you?
Yeah.
Thank you. The other problem with this is that most of the work that you guys are doing is based in the community. Our problem on the other side are the physicians. And so, like you said, middle management is supposed to be holding the nurses accountable, but who's holding the physicians accountable? So like I was facilitating a group of OBs, and so I did that for like 7 years. And every single month I would provide them with articles or whatever that somebody mentioned that they don't read, data that they weren't reading. A couple of them were saying that they don't have bias. And so what that was telling me, and what that continues to tell me, because they still practice the same way, is that if they would get an African American patient, that patient's not being heard. And so a lot of what's happening with the outcomes is because the patient's not being heard. The patient is saying something, it's not being heard. That's why we're having the outcomes. And so you can do all of the stuff that you guys were showing up on the screens and everything, you can do all of that all day long. But if that provider is not listening to the patient, you're going to have the outcomes that we've been having. Nothing's going to change until somebody holds physicians accountable, period.
No, I mean, I could not agree more. I mean, this is actually why Roots exists, basically, because at some point I said, I don't have time to try to change all these other people's hearts and minds. We're going to have to build it ourselves in the community, with the community. So you're going to see a Black physician when you come to Roots, and I would like to see that spread nationwide, right? We need more HBCUs training. I mean, all schools, obviously, but our historically Black medical schools were systematically wiped out, right? We need to build those back. We need more graduates. So we need a more reflective workforce at every level, right? Every single level, physicians included. And who's holding the physicians accountable right now? I mean, I think I would have to say the doulas are holding them accountable. And that's not right or fair or equitable. It's the stopgap in a lot of ways, but it is a critical workforce that helps to bridge gaps. A lot of times what we're seeing is because healthcare has earned so much mistrust in our community that people are not advocating for themselves in those spaces because it feels futile. And a lot of times people are not even presenting to healthcare until things are further along than they needed to be. And we all know too many heartbreaking examples of that. And it's not just in maternity care, right? It's in oncology. It's in so many different spaces where if you feel like these people don't trust me, they don't understand me, they're not hearing me anyway, then you have whole entire institutions where our community just doesn't feel safe or cared for. So this is what we're up against. So there's really no sugarcoating it as far as I'm concerned. I appreciate you just being, forthright with it. Yes, we should continue to do bias trainings and all those things. I'm not going to be the one doing them because I will be busy building something that is this response I want to see in the world, right? So we all have our role in this. I pray for the folks that are inside institutions that are trying to make the change because that is some of the hardest work. And I feel deep gratitude to every single one of you. It sounds like you might be one of the people. I hope that you take care of yourself. Everyone who's doing this from a place of, we call it like the inside outside strategy, right? So we know that we've got allies inside institutions that are doing amazing work. And I hope that you do the healing work that you need to take care of yourself, because all too often we find people either give up on those ideals because it's too hard, or they burn out, or they leave. And we need allies in every single space. And so I agree with you. And I think we have a long, long ways to go. And I think there's a lot of things that all of us are obviously trying to do to mitigate that. And we have a ways to go.
For more responses from the panel, and then we'll feel that looks like we have some response from the audience too. Go ahead.
I can't see her anymore. There she is. You're beautiful green. Thank you for the question. And it's so funny because I had just written down internal and external when she had mentioned that. So I want to start internally. And there might be some folks on the live stream today that attended a meeting we had last week at CMQCC. And I happened to mention that unfortunately, and all I know is healthcare, that unfortunately in healthcare, if you're a good nurse, maybe clinically, you're a good doctor clinically, you may be put into or chosen for a leadership position. That's not how you choose a leadership position. Amen. Okay, right. So there are people, unfortunately, who are leaders that probably shouldn't be leaders, right? And what does that mean? There needs to be other leaders who are going to step up and identify, and there has to be accountability. So there's the whole internal, right? And then you get into boards of directors, a whole bunch of talk. The other thing is, let's talk about externally for a moment. Know that the Joint Commission, one of the foremost regulatory agencies of hospitals in the United States, when they do their surveys at the end of the week, they have what they call, I think it's called a leadership conference, and they invite folks who, are leaders at the institution to come to their summary talk. And at their summary talk, they are talking about equity. And they are asking doctors, they are asking nurse leaders at that meeting, what are you doing? And what are because our CMS regulations, so it is tied to payment, right? So there are, again, the internal, where folks need to step up, have those tough conversations, and there's the external. There are regulations, and they are tied to payment.
Anyone else on the panel respond? Yes, yeah, of course.
Our other hero.
You could also drop a dime on folks. You can call the insurance company, the insurance providers, whether it's Medi-Cal or other, they all have lines for that. Within many public health departments are facility inspection units. And, in LA, when we had a couple of Black maternal deaths and the circumstances were very wrong, we called the facilities inspection unit, who went out and visited and opened an investigation sooner than at the state level, which they did as well. And I think part of it is finding what are those, I'm sorry to say it, dime drop places within your county where that can be possible, where the money comes, like payment comes through. So I'm sharing that as Melissa. That there are, yeah.
Hi, morning. Lynn Lee, I've been a midwife for 45 years, actually 46, getting there. Soon to be 69, I'm in your camp. I delivered 2 babies yesterday. It's a beautiful job. Great. I know, I'm on my knees all the time, I'm telling you. But the question, I am institutionalized, unbelievably. But it's an amazing job, right? But what we have to do is start from that bigger picture, because it's a systems problem. When you speak of the doctors, I can tell you they are in dire straits out there. They really are. They have 10 minutes to see these patients. Education is key in this world of ours. Our practice, I started BAM, Bay Area Maternity, 2012. I got money from Google because I delivered their baby, and Yahoo. Thank God there's money out there in this Bay Area. We have to go and bring in the money. We're not going to get this done without money. Everyone has to help each other, right? And you can tell I'm shaking. But when I'm catching a baby, I'm calm as a cucumber. I'm telling you. 2 weeks' time, I'm going to China. I'm a keynote speaker. I better take my Zoloft because I'm going to be talking about the same sort of things there. Those midwives catch babies. That's all they do. They're not in the antenatal floor. They're nowhere. The doctors are running the show. So when these patients come to labor, they're all asking for a C-section. It's messed up. We have the lowest C-section rate in the Bay Area, over and above the home birth midwives, let me tell you. Why? Because we do what these women want. You need midwives in these systems. That's what you need, right? Honest to God. It'll make me cry, because I'm crying, because I've been on your conferences and I cry. I can't help myself, because as a 16-year-old woman in England, child, I saw a dead body laid out. I left home at 17 because I wanted to be there to help people. By 19, I'm catching a baby. Can you believe that? So here we are, and one woman said to me, beautiful sister, she said, you need to put yourselves in that patient's shoes. I don't see color. I see women. That's what I see. And I'm as white as a sheep. But I see women. We're all in the same boat. Please, it's the head up there. Get the money coming in. Thank you, thank you.
Anyone else want to speak to holding peers accountable?
Yeah, holding peers accountable, I think to me is just speaking truth and bringing in voices of maybe folks who aren't in the room or aren't at that table and just understanding that that's part of my role as a leader is not to talk about my opinions or thoughts on things. It's really to do the reality check. Sometimes holding accountability is also, aside from looking in the mirror, is holding up a mirror too, right? And making sure that people see, if they are part of a system that is producing consistently inequitable outcomes, then what is their responsibility towards that? Because oftentimes we find that gets normalized. Like, oh, well, that disparity's been here forever. And, oh, well, it's probably this, it's probably that, it's probably drugs, I've heard, all kinds of rationalizations, right? But then you can't start talking about how you're doing an equity thing if that's how you're approaching inequities, right? Yeah. So I think holding people accountable to not just checking a box, but saying, well, then how are you? Because if you're going to try to deal with a long-standing disparity or inherent inequities, you're talking about having to change systems. You're talking about having to disproportionately invest. People don't like that part, right? But you will have to disproportionately invest. So it's not enough to say, well, we're only 3% of the population, or, well, we've always had that disparity, right? So I think holding accountability is like not normalizing what really is abnormal, and also continuing to bring facts, definitions, not allowing a word to just become overused, kind of thing, but really to kind of hold some integrity around that.
Something about accountability. I kind of want to build on, I just want to shout out my doula colleagues, because I mean, again, I think every profession plays a role, but doulas are out here doing heavy lifting, and in birthing settings, I will say. But I guess I want to be hopeful, because I think there is change happening. I don't know if the folks in here agree with that, but I have a doula colleague who taught, I think they started maybe 5 years ago. They did a grand rounds. I'm not going to say the city, but it's in the Bay Area. And so it was primary physician attendees talking about doula supports, and this is the egregious example. It wasn't like this across the board, but they had physicians laughing in the audience. They had physicians walking out when they were talking about the benefits of doula support. So I mean, this is it. Not all hospitals were like that, but this is true. This is maybe 5-6 years ago, and now things are changing. Like, I don't think that would happen. If they did a grand rounds today, it wouldn't be allowed because of leadership calling it out. And I do think things are changing. This is just in this particular space. But it didn't just change because time went by. It's intentional work that they've been doing. In this case, the doulas have been doing work outside of the birthing settings and prenatal care. They've been accountability, calling people out. They've created a mechanism so that doulas can actually formally report feedback on the providers that they've been dealing with. And they've done some other stuff. If you're interested, talk to me, because I can connect you with these doula colleagues, but also our team is trying to, back to data and evidence, we're trying to evaluate that so that we can then put it in the peer reviewed journals and say, look, this is something that can start to create accountability, like systems change and accountability. That's where my team tries to come in, which is to bring that evidence. But I just want to say, I do think things, at least what I've observed as a non-clinician, this is someone kind of outside the clinical setting, full disclosure, but I think things are changing, and I think doulas are a big part of that. And again, they're not the solution to fixing the system, right? But I do want to call out the work they're doing. And I also want to say to the last speaker, thank you for what you offered. But I also want to say personally, for me, it's okay if you see color. I think that's good. I want you to see my color. And I just want to elevate that.
Thank you, Dr. Marshall. Okay. Great.
Whoa, that became very loud very quickly. From one of our colleagues, Anna, and as we're talking about accountability, wanted to make sure to tie this in. But the Perinatal Equity Working Group is also a space that is in this holding folks accountable, and wanted to propose that question to you of how is that working in helping with holding hospitals and systems accountable.
That's a question for me?
That's for you. We're qualified to answer that
Okay,
question.
I am not a panelist. I'll be super brief, and then I'm going to get to you. I will say I was not prepared to answer any questions. I will say that I think the primary mechanism for holding people accountable, as we've done work in the Perinatal Equity Working Group, and there are a lot of members here from the working group. Maybe raise your hand if you're a member of our Perinatal Equity Working Group. Yes, thank you so much for being here. So I think the primary mechanism for that is probably the relationship building. Because, and there has been times where, something happens that kind of like causes us or inspires us to kind of go to those relationships and just talk about it. I want to say that. So yes.
It wasn't so much a question as we need to shout out the Perinatal Equity Working Group and maybe try to bring in some more folks who are interested in this accountability and systems change piece. I just didn't want the Perinatal Equity Working Group to, just float on the sidelines. It's important. And,
Thank you.
And I want to see that work raised up and more people to join it.
Thank you. Thank you, Anna. Thank you for that, for amplifying that intervention that we do with hospitals. So I know we have slides that are kind of flashing throughout, and you'll see them on break. But our Perinatal Equity Working Group, as I think maybe Supervisor Ellenberg had mentioned, convenes healthcare staff and different folks involved in caring for perinatal patients across the county. And so, yeah, thank you. Thank you for uplifting that. Okay, let's see. Yes.
Thank you so much. First of all, thank you all. I feel very fortunate and honored to be here. It was a very wonderful presentation by Dr. Melissa, very deep. And somehow I know all panelists at different levels. So I was going to say something before the question was asked, which was the same thing, the same comment that I was going to give in regards to accountability, because we were talking about clinicians. One of the things we do in our Perinatal Equity Initiative work is also thinking about root causes, right? Root causes, structural issues. For instance, there are very few institutions, universities, that provide disparity classes. When one is taking their master's, it was an elective and I took it. And that's where I learned. Even though I have a lived experience, I want to shout out to my professor, Dr. Philip Gardner, was the one who opened my eyes that there are deep disparities and inequities that lead to deeply rooted health outcomes, really bad health outcomes. Shocking, right? So I think we need to start before people become doctors, before people become clinicians. That's where we need to change policies. I know Dr. Melissa was talking about earlier, I think policies, trainings, now we have the implicit bias training, but only training people are not going to do anything when they're already clinicians, right? So let's start changing policies on how our institutions and universities and colleges work. I know this is not a good time, but we still have hope from what we've seen this morning, right? And so we can start from that with our Perinatal Equity Initiative. Whenever we hear something in spaces, let's say our doulas are having issues or there is an unwelcoming environment, then we try to advocate. We try to connect. I always say, connect with Christina Oldini at CMQCC, So it's like our connections network, our sisterhood, brotherhood, everything needs to come together before people become clinicians. And after, then we can advocate through our doula team, through our father engagement specialists, through our BIH, FHAs, and through you as well, right? I followed you when I was a mom, becoming a mom. I learned a lot from you. I know Niambi from the state through work, Christina, whenever I want to advocate something for health systems, I always connect with her and connect with all of us. And then Dr. Marshall, I know her from when I stepped into this country, a very huge advocate. I participated in your community inclusive research and work. So that's the only thing I wanted to say. Right? Thank you.
Yes.
Speaking from a nurse executive quality individual, the key to accountability lies on leadership. In that, we must promote an environment of a just culture where everyone feels that they can speak up and stand up. Now, that's tough to do, but it's not impossible. So it starts there because it's not one or two groups who are responsible, it's everyone. If you see something wrong, say something. That's tough to do because people are afraid, but that's where we have to start. And if you are focused on it, you can implement that in your environment for whatever environment you're in. So just culture to get the employees, to get the staff, the leaders, the doctors, the nurses, everyone involved in it. And that does help with promoting patient safety.
Thank you.
Hi. Sorry. I think I need to stand up. Hello, everybody. It's such an honor to be here, and I applaud all of you for the amazing work that you're doing. There seems to be a historical silent war that goes on between nurses and physicians, and it has been ongoing for years. And as we continue this work, it's important that we go back and reassess how we are leading, right, to revisit our why and how we re-strategize. Sometimes when we use the word accountability, it tends to carry, in some ways, a negative connotation to it. And so I start looking at things from a collaborative approach. And so if we've had processes and protocols that have not worked well, and we don't see that people are doing what we expect they would do, the first question is, do they understand the why and what needs to happen? Who's leading the effort? In my organization and in our department, the maternal child health space, we have done a lot of work to build those relationships, to build trust. I don't think there's any bad person, physician, nurse. I don't think there's anybody who wakes up and says, today is the day I'm going to hurt a patient. But we do, unfortunately, hurt our patients. So how do we re-strategize? I think we need to start by building those relationships and trust and having our physician leaders at the table where the conversation takes place, because sometimes they feel, oh yeah, you come up with a plan and you tell me what to do. I'm not doing that, right? I'm intelligent enough, and we know they are. And so I urge all of us to start taking on a different approach to see how we can bring our physician partners along, because we cannot do this work without them. Thank you.
Thank you.
I love that we were able to acknowledge. I have a question, but I do want to say I love that we were able to acknowledge that doulas are managing providers. I've done this for so long that unfortunately I have learned the art of disassembling ego within hospital spaces. But one thing that I have not truly feel like I see happening, and that's what I'm going to ask, is that how are we allowing a collaboration of doula relationship inside of the hospitals? What are we doing to make that better? Because right now, all I see is nurses are now going to school to be lactation specialists. And they're saying, oh, I'm a lactation specialist, you don't need that. Or they're going to school to be doulas. You don't need a doula, it's okay, I got you, I'm specialized in this field. As if they don't want to collaborate. They don't want us in their spaces. And I've worked from Sacramento, Vacaville, and then I came to the Bay. And when I came to the Bay, it was beautiful. I was like, see, I told you we could do it. We're just that little wedge to give support. And then I just moved here and it was like, oh, I'm starting all over. So what I want to know is like, what does that look like in you guys' realms of creating a collaborative space with doulas?
Thank you for that question. First of all, I want to shout out Santa Clara County Perinatal Equity Initiative for their series this past year, or Shilpa, all of you, on doulas. If you have not seen it yet, please look at it, okay? Because that's systems change, right? So let's talk about many of the players, the folks that are doing this work. PEI, qualitative researchers. Everyone needs to leave this room today knowing what qualitative research is today. You know, regular research, right? Very respective, randomized controlled trials. Dr. Franklin talked to this earlier. The data, the hard data, right? We need to pay attention to the qualitative data. That's the stories. That's the people's voices. That's what they're telling people. One of the biggest gaps I feel we have on nursing units is when we, in some, not all, is where leaders round on patients, that info never gets back to the staff. It will get back to the staff if it needs to go to coaching or counseling or termination or something like that it's so egregious. However, just improvement that needs to occur doesn't even get back to the rest of the staff. DHCS, working with doula leaders across our state, right? And that's happened, that's systems change. And I want to, shout out our partners, which include, it's from CMQCC, DHCS, the Department of Public Health, and the California Surgeon General, Dr. Diana Ramos, for their identification to make systems change, because they know the data. They know the quantitative, but they know the qualitative data and what patients say who work with doulas. Right? So I hope that kind of speaks to what's going on and how we have to do it. The other thing is at CMQCC, we've learned that we need a model. We need to model. We can't go out. I have a tough time. I'm a nurse. I sit at a desk, right? I don't touch people. I don't, I've lost, it's such an important part of my life. We have to talk to people. We have to model working with doulas, working with community, working with public health, working with qualitative and quantitative researchers, working with incredible organizations like Roots. That's what we have to model, right?
Yeah, I would just add, I think, you all know how hierarchical medicine is, and the culture is really toxic in a lot of ways. I say that as a, physician who's trained here, who, I'm just saying that, the way that it's structured doesn't lend itself to what you're talking about and what we all know is actually needed. There's not a lot of humility built in, right, around like physician training or being a doctor. And the ones who do display that humility are the ones we love. Like that's my doctor, when you find that. I think that there's a few things. I think one, I do feel that it starts with the patients understanding their rights, understand and feeling empowered enough to say, you know what, this doctor is not listening to me. I'm going to vote with my feet and go somewhere else. And that's something that it sounds so simple, A lot of us would do that. You go to someone and you're like, no, I'm gonna switch doctors. But for a lot of our community, they don't necessarily feel that they have that agency within systems. It's like, well, I'm just gonna go there. I'm just gonna get mistreated. I'm gonna see if I can get what I need. And hopefully I don't have to come back, right? So sometimes just making sure that our patients know, like, vote with your feet. You can go somewhere, someone that does care about you. I think the other part, and I do think this goes towards how we hold systems accountable, is I think every hospital should know its disparities within their population, right? And the way that these things are measured, I mean, it just drives me up a wall, because it's never really about, okay, this cohort of people, did they get better? Did they get worse? It's always about at one point in time. So the way the health plans measure, right? Here was the A1Cs of everybody, this date, and then here it was on this date. It wasn't about, did this patient get better? And that's how I think we need to transform things. So as much as we do need to honor all of the richness of qualitative data and research that we can bring about, the quantitative data is already an indictment that people need to see, right? And I don't think necessarily a physician knows, ooh, I have really bad outcomes when it comes to Black women. No physician sees that on their report cards, right? That's not the way we reward in our system. And so a big part of it is, how do we change that, right? How do we basically say, well, if this hospital is producing equitable outcomes, they get more money, right? Not just how do they talk about their equity work, but the proof is in the pudding, right? So I think we need to get towards some of that. But I think some of the hopefulness to your question is like that Medi-Cal is now paying for doula benefits. Like, that's a huge legitimizing, as factor, right? And so knowing that that is an actual benefit that people are entitled to, and making sure they know they're entitled to it. Because doulas, at not too long ago was like, oh, that's what wealthy people get, kind of like a coach, right? That's what wealthy people get. No, everyone can, right? And so I think making sure that hospital administrators, who oftentimes are the ones that are making it so that the doctors only have the 10 minutes or whatever, right? That the hospital administrators know, okay, this is a paid for benefit, and it's improving outcomes, and it's improving your, equity scorecard. I'm just making up an equity scorecard, but I think everywhere should have that, and the payment should be tied to it.
You heard it here first.
So hopefully we'll go there. Okay, yes, you heard it.
You coined that. There's a question in the audience. Did I miss?
Oh, yeah. There's one here too.
I just want to add something. We just talked about our doula series that we had, doula town hall series, where we did bring up all the concerns that doulas has in our county, right? We talked about how they can integrate into the workforce. We talked about how many doulas are there in our county, right? Now that Medi-Cal benefit is available since 2023, we are struggling to still increase the number of doulas in our county. And that's why we really want to team up with healthcare organizations to get some funding, because as a public health department, we have a limited funding, which we are providing doula services, but we need more funding to bring more doulas on board for doula trainings and for their continuous education. So I think there is a gap, and I really want us to focus on that gap. Yeah.
Thank you, Shilpa. We have a question over here.
Hi, Wayne Uptrina. As the Black OBGYN doctor that practices in the community, I want to start out with a huge shout out and appreciation for the Perinatal Health Equity Program, and to say how lucky I feel to practice in a community that has this level of support for my patients. Sitting here, yeah. I'm not going to lie about the fact that I feel a little bit of a heartbreak hearing a fair amount about the adversarial relationship between doulas and physicians, which is not something that has to be. It is something, for sure, there's a lot of different reasons for that, and that is something that probably should be acknowledged and, highlighted, but also then we have to learn how to move forward and work together. Everybody in that labor room has a role to play, a significant role to play for the healthy outcome of the mother and the child. And I think when everyone plays their part well, the patient wins, that baby wins. When we get into adversarial relationships in a labor room, nobody wins. And this is something that, as important as the role of doulas are, and I'm a huge supporter of doulas, I always, when my patients ask me about references for doulas and how do I feel about the role of doulas, I always acknowledge the importance of a doula and the overall role that kind of the labor room space, and now we're using postpartum space as well, which I think is amazing. But, you know, I'd say just make sure you kind of advocate for your needs and your wants very clearly, understand what the roles are, and have someone you choose that you feel aligns with what your desired, you know, process of labor looks like, and then you work together. I invite the doulas to come to their antenatal care, and I've had a few of them come in with a birth plan and go through that together as a team. We have to work as a team if we're going to have healthy pregnancy outcomes. There's been a healthy amount of focus on labor room issues, I think, importantly, and a healthy amount of emphasis that I've heard this morning on processes, structural and sort of systemic issues that kind of get in the way that have to be addressed, and everyone is doing valiant effort in that space. But I also really want to emphasize the importance of working with the primary care community and the Perinatal Health Equity program to identify an opportunity before pregnancy, you know, to kind of optimize the medical conditions that cause poor health outcomes. And I think doing all that we do to just highlight structural problems in the hospital is not enough, right? I mean, the toxic stress and weathering that researchers have identified that really then put Black women in the poor health outcome circumstances are the things that we really have to target early, preconceptually, and working with primary care physicians and gynecologists to identify those patients that are at highest risk, and then, you know, educate and sort of self-advocacy and, you know, caring for yourself, and also getting the proper amount of sort of like optimal conditions for your medical before you get pregnant, so that you can get into the OBGYN world and then have a healthy prenatal care surveillance and a healthy pregnancy outcome. I think we can't really just talk about what happens in the hospital, right? Okay, that's all. Thank you.
Thank you, Dr. Chene. And also thank you, Shaylin, too. Shaylin's one of our CAB members. Thank you for that question. That sparked a really beautiful discussion that integrates doulas. And I want to also shout out that 2 of the 3 installments of our Doula Access Town Hall series are on our Deliver Birth Justice YouTube channel. If you want to check out the recording. Okay, I'm going to close this out with our panelists. If you'd like to answer a 2-part question, you can answer either question or both, and then we're going to excuse everybody to lunch. And so, related to the theme of this year's Black Maternal Health Week, part 1 of the question is, how do you stay rooted in justice and joy? Part 2 is if you have a call to action for our audience here today.
How do I stay rooted in justice and joy? I have 4 beautiful nieces. I love them dearly. I'm a boy mom, so I love the time I get to spend with my nieces. And how I stay rooted is thinking about the fact that I want them to have happy births if they decide. And so I know every day I'm doing work that's going to help them to do that. And my call to action, I would say, just thinking back on Melissa's presentation, structural racism is here. It's not going to change overnight. It's not something that we're going to have a big impact on right away. But think about the small things that you can do every day that can support having Black mothers have the happy and healthy births that they want.
rooted in justice and joy with the people I surround myself with. And I also have a 27-year-old, God, I'm into ages today. I have a 27-year-old son, and I've been around him when I've been in conversation about this work, and he'll be there, and they will say to him, your mom, so-and-so, so-and-so, so-and-so. Whew, boy, does that, right? And then the last one I'm going to say, my call to action, care. Just care. However you choose to care is up to you. But please, you need to care about this. We all do.
I could go. Yeah, so staying rooted, yeah, that's pretty easy at Roots. We're surrounded by by so many mission-aligned folks that it's just inspiring. So if I ever start to feel you, I can talk to Alma, I can talk to Kimka, two of our fearless leaders in maternal and family health in the room. And yeah, I appreciated the doctor's comments earlier, and it definitely made me think of something that Ms. Alma always brings up around like trimester 0, right? Before you're even thinking about getting pregnant, right? Or 4th trimester, like afterwards, that we think of people as whole, with their whole selves, a whole entire person, a household, a family, a neighborhood, a community. And so I think my call to action would be for us to always make sure we're just taking that step back. You know, maybe at this moment we're worried about the delivery room, or we're worried about, you know, that prenatal visit. But then we know people drop off, they drop out of care. We only care about them while, you know, while they're pregnant, and then forget about them. And so just remembering that the clinical care part is the smaller percentage of what actually determines their health outcomes. And so that we need to be thinking about how are we acknowledging and taking some responsibility around all the conditions that are leading to the poor outcomes, which go beyond that. But then also holding ourselves responsible and accountable to the part that's our role as well. And then the last thing would just be listening. And really collaborating, right? Like none of us can do this on our own. And so I think some of the collaborations that have led to today, our collaboration with the county and with the public health department, are so phenomenal, because no one is sitting in their office going, I have this all figured out, right? Yeah. We've all reached out and said, look, let's each bring the gifts and the talents and the assets and resources we have to the table, and then that's how we can solve this.
I'll just briefly add, I think the justice and joy question is where I started, which is just seeing amazing people enter the workforce. Mm-hmm. Like, the kids are all right. Like, they're really, really amazing people entering the workforce in this space, whether it's in, you know, clinically or in public health or in research. I feel really, really in awe of the people who are graduating today. So that really makes me happy. And I guess I was trying to think, do I have a call for action? I guess I would just say to embrace our multiple identities. So by that, I mean, all of us have many identities in this room. You might be a physician, but you're also a patient, right? You might be a public health leader, but you're also a mama, a Black mama in the community too. And same as me, I'm a researcher, but I'm a Black mama. I've, you know, and so many doulas have supported me, midwives have supported me. And I think sometimes when we embrace all those identities, we don't silo them. We can see each other's humanity more. So I think just embrace all the pieces of who we are, and bring that to our work as well.
Thank you. Beautifully done. So I'm going to ask everyone to just give a final round of applause for our wonderful, esteemed panelists. Thank you for so generously offering your insight